And we're live. Welcome to another episode of EM Board Bombs. I'm here with Dr.
Happy to be back.
Briggs. I'm
Happy
so
to be
happy
back.
to be here. It's Dr. Wosiski, in case you didn't recognize my lovely voice. And we're excited to talk to you, hopefully, on this week of Thanksgiving. And everyone's enjoying their food and family and being
And
thankful
football.
and football, the
Yes.
other important F of
Yeah.
Thanksgiving. So
Yes.
we're ready to deliver some educational pearls today. And
That's
Dr.
right. EM Board
Briggs.
Bombs, 10 and 15-minute
Yeah.
episodes where you get amazing high-yield knowledge, life pearls. We're going to tell you what our favorite dish is for Thanksgiving, too. There's going to be a clear winner. I wonder what if Iltfat was here, what he would say his dish would be. It would be something we both would be surprised to hear, I'm sure. He always
Yeah.
comes left field with something.
Yeah.
It'd be like some type of fruit salad or something. All right, let's dive into this stem. So a 42-year-old man presents to the ED with sudden palpitations that began 3 hours ago while hosting a Thanksgiving party. He reports drinking, quote, just a little, which upon further questioning, this happens so often, right? You go back in the
It's
room
never
where you question
that.
further. Yeah. Questioning, he admits to then 8 shots of bourbon and 3 ice cold beers. No past medical history. He's a healthy person, 42 years old again, no medications. He denies any chest pain or shortness of breath or fainting. He's upset, though, that his fantasy team did poor and 2 of his starters apparently were benched due to, quote, woke concussion protocols. Again, healthy guy, 42 years old, has a fast heart rate. His vitals, temperature is 98.4, his heart rate's 148, blood pressure 126 over 72, and his oxygen level is 99% on room air. You look at the EKG, and we wish we could just hand it to you right now, virtually, right? It's the one downfall of podcasting. And let's just say it shows AFib with RVR. We won't even try to make you guess.
Yeah.
It's an irregular rhythm. How about that?
Irregularly irregular.
I wonder what it could be. No ischemic changes. All his labs are normal. TSH normal. Okay, so based on all that information, Dr. Wosiski-Kuhn, which of the following patients is safe for ED synchronized cardioversion without anticoagulation? Choice A, this patient, only because symptoms began less than 48 hours ago. Choice B, this patient, only after you get a CT head to rule out intracranial hemorrhage and ischemic stroke. Choice C, not this patient, only those less than 12 hours without risk factors. Choice D, no patients with any acute onset AFib should be cardioverted in the ED unless unstable. This is a great question.
This
A little
is.
wordy, though.
But while we think about it, you know what I'm going to tell you about?
Please.
I'm going to tell you about rapid bombs. And
there we go. That's perfect. Do it.
Yeah,
Get in
that's
the
right.
holiday spirit here.
The holiday spirit of rapid bombs. And you know what could make a great gift for
Yes.
someone that you really care about? Maybe a co-resident that you've been wondering what to get them
Yes.
for your Secret Santa. Maybe EM rapid bomb subscription. You could
Yes.
give them
Yes.
the little extra knowledge. Maybe tell them that they should be as good as you.
Yes, your dog agrees too.
Yeah, I know. He's out here just cheering me on with encouraging some rapid bombs. Rapid Bombs delivers tons of educational pearls in 3 to 5 minute episodes delivered straight to your inbox of whatever streaming podcast service you like. So you can sign up today on our website, emboardbombs.com. Links are on all of our socials.
Check it out.
Check it out.
Hey, so what's the correct answer? 42-year-old male.
Yeah.
Healthy, AFib, drank a lot of alcohol.
Onset of palpitations 3 hours ago. So
Perfect.
that patient, choice A, is safe for synchronized cardioversion in the ER because his symptoms began less than 48 hours ago, and he does not have any stroke risk factors.
Yeah, so this patient has the classic holiday heart syndrome. This is something that everyone learns in med school. We hear about this condition. I feel like lay people know about this condition too. It's just well talked about. And it's interesting because, you and I were talking about before this podcast started, we're like, have we not covered this yet? I mean, I feel like this has been such a mainstream thing that's been going on. And I actually, last month, I had 2 people literally 2 days in a row that I cardioverted and sent them home. So let's clarify here who you can safely cardiovert in the ED. Obviously, these are stable patients. We're not talking about the unstable patient who is hypotensive or altered or very sick looking that you are cardioverting out of necessity, right? These are the patients that you are electively cardioverting. And this topic always gets people nervous. I'll admit, when I first started doing this too in my practice, I was a little bit nervous going home, and I was like, did I really do that right? Because there are people that go upstairs and get their echo, and then they get, anticoagulated, and they get cardioverted in the cath lab, and you're like, and I'm just a cowboy downstairs doing it blindly, you know, but
Yeah.
these patients actually are really, really safe. So why don't you talk about the big 3 decision points that you're thinking about in picking these patients? And then, of course, talking about, you know, where we go from there, the classic presentation, all that.
Right. So there's 3 big decision points that you're going to have in your head whenever, you've figured out what this patient has and you're talking to them and you're trying to decide if they're going to be safe or not. And those are the duration of symptoms, their stroke
Yeah,
risk, and is this like a reliable onset of their symptoms? And
totally.
something that I like now is when I see that they have an Apple Watch on or some other kind of
Yeah,
tracking device, I can add, like, do you have your abnormal heart rate monitor on? That can help you with the reliable onset part of things. And yeah, so every Thanksgiving, the ED is going to fill with these people. I mean, all through the
and
holidays,
Christmas.
really,
Yeah,
Christmas, New
next
Year's.
2 months, basically. Yeah.
Yeah. Yep.
Preheat the
So
pads.
yeah, get ready because the ED is going to fill with these people who are
Yes.
not in college anymore and cannot pound 8
Yes.
shots of bourbon because they're upset about the woke concussion protocols, the NFL.
That was funny. So true. So true.
Yeah. So, this patient is classic holiday heart. So doesn't have any structural heart disease, sudden onset of
Perfect.
palpitations. He could feel them when they started. It was triggered by binge alcohol drinking. He's hemodynamically stable. As you could see, like his vital signs were totally normal. He was not altered. And the clear onset of less than 48 hours. There was like a trick in there where it was like had to be less than 12 hours. It doesn't need to be that recent. So this
Correct.
patient was prime for ED cardioversion. So, Dr. Briggs, you want to talk a little bit about the reliable onset side of things?
Yeah, understanding first, you know, holiday heart can include other arrhythmias too, but it's just most commonly AFib.
Yeah.
And we mentioned this patient is just a perfect example that they were drinking a bunch of alcohol, they were young, and they have totally normal labs. So of course you're going to wait on, you know, their like laboratory tests and imaging. If you can do a bedside echo, that's great too, but it's not going to change too much in your management decisions. The big thing is a chest x-ray, your CBC, BNP, thyroid tests, magnesium, all
Yes,
that
get a
stuff. It always
mag.
makes me upset. Why doesn't a mag come on a CMP? Can we
Oh
talk
my
about that?
God. Yes, please get a mag. If these
Why
people.
why is this not a thing? Like, I would totally sacrifice 3 other items in the CMP to get a mag on a
I know.
CMP.
Yeah.
I mean, I'm trying to think of all of them. Number 1 would be an albumin, let's be real.
Right. I was
I would
going to
totally
say
get rid of an albumin.
the times I've cared
I'm
about
trying to think of all the things
albumin.
I'd get rid of. Well, even a BMP, really. I mean, it's there's so many things that come on a BMP as well. Like,
Yeah.
let's be real. The only things we really care about is going to be a potassium, a sodium, a creatinine, a CO2.
Like, I don't need the chloride.
Anything else? Yeah, exactly. Does anyone really? Yeah, the chloride, the forgotten electrolyte. There's
Get
some
out of
nephrologists
there.
out there listening to this. Like, just they're totally going to comment. This is going to end up on Instagram, and there's going to be a nephrologist that's going to make fun of us. Usually, it's a
Yep.
surgeon that comments on us. You know,
Some
It's
surgeon
gonna be
that
some
cares about
nephrologist.
chloride.
Yeah, exactly. Yeah, exactly. Anyway, okay, so most of these episodes with these patients, they actually do spontaneously convert. They actually do move from AFib back to sinus rhythm if they're young and healthy within like a 24, 48-hour period. But the fact that they're in the ED usually means that they probably haven't converted yet, and usually also means that they don't need to sit in the ED for a full day, because you're probably not going to send them home, right? Because the vast majority of these people would benefit from a cardioversion. They shouldn't go home with AFib. It's new onset. We should try our best to get them out of the AFib. So if you're going to do that, the incentive here is to decrease boarding, decrease their contact points in the hospital, and get them out of the ED sooner.
Mm-hmm.
And so the first point here about this decision framework, which we're going to go through one by one, is the AFib duration less than 48 hours, and it's reliable. And you said a really good point here, talking about the Apple Watch. That's really, really helpful. And I do the same thing if they have an Apple Watch, or sometimes they tell me such a good, distinct story, like, hey, I was putting the laundry away, and this immediately happened right when I was doing that. At this time, I looked at my phone
Yeah.
or clock. That's helpful. What's really sketchy, and it's when it's overnight or when it's like an older person, and they're like, well, if it's an older person in general, they're going to be higher risk, but they're telling me the story of, yeah, I mean, it was around 3 days ago, you know, and that's just not a good sign. They just don't really know. The fact they can tell you the exact time is really helpful. So less than 48 hours, reliable onset, that's like one of your first gateways of like saying the entertaining option of, okay, this patient could benefit from a cardioversion. Why don't you talk about the second differentiating factor here, which is their stroke risk?
Yeah. So for episodes under 48 hours, you're going to then look at I still just say like the Chad's VAS score, but there's a bunch of little twos
Sure.
in it now.
Yeah, it's on like version
Yeah,
5.0
it's like
now.
Chat2, DS2, and like, I don't know how to say that,
Yeah,
but
it's
you know that
absurd. Yeah.
there's an updated version of the CHADS fast score.
Yeah.
So you are going to calculate that score. And then for higher scores, you can still do ED cardioversion, but you're going to start anticoagulation afterwards. And that's because of the risk of myocardial stunning. But if it's a
Yes.
young, typical person that gets holiday heart, which is usually that person, they're going to have a CHADS fast of 0. You're not going to need to do anticoagulation.
Totally.
Again, talking about non-holiday heart people, AFib greater than 48 hours. Remember, the anticoagulation is mandatory prior to elective
Absolutely.
cardioversion, unless somehow you can get a TEE from the ED, in which case, good for you.
You have that out in Pagosa Springs, right?
Yeah, we do bedside TEEs in my small rural ED all the time.
Yes.
I don't have a
I remember
TTE
that
probe, but I can do a TE.
that was such a big thing, I think, around 2019. I went to ASIP that year, and that was like every other lecture was talking about TE in the ED. And it was like the big topic of the year, how this is going to change everything. And it sounds great. It sounded wonderful when they were talking about it. I'm like, how does the average, I mean, we still don't even have ultrasounds at some rural EDs in this
Yeah.
country. And we're talking about moving TEE to bedside anyway. It's the most ivory tower thing ever. So the last thing is going to be the hemodynamic instability. We just have to mention this. We mentioned in the beginning. This is a no-brainer. Just understand that anybody that's unstable gets shocked immediately. You're not even going to think about these discussion points.
Yeah.
Any shock, meaning hypotensive, obviously, any ischemic changes in the EKG that are persistent, and signs of pulmonary edema, acute heart failure symptoms, or the patient's just altered. These are all signs, and intubation, right? That's another thing that is a sticking point. And somewhat weirdly controversial. We talked about that right on a podcast, and it went on Instagram. And people were like, well, I can't believe you would shock them and not intubate them first. And I don't know what people are thinking, that you want to intubate someone with an unstable arrhythmia and then they will code. So you should be shocking first and ask questions later. Anyway, so this bypasses all the rules. Unstable patient, shock them, ask questions later. But our episode today, we're talking about elective cardioversion. Go over the contraindications again to the elective cardioversion just one more time. More time so we get everything down, and then we can wrap things up here with reviewing the wrong answers.
Right. So contraindications to immediate cardioversion. And we're talking about elective cardioversion in the ED. You cannot cardiovert someone in the ED if their AFib has been greater than 48 hours or if there's an unclear time of onset, if they have had a recent stroke or TIA, if they cannot receive anticoagulation, if that's indicated. So you could do things like the HAS-BLED score. If there's no reliable witness or history to determine the onset, or if you suspect underlying structural heart disease that they're hiding from you. So like you hear a really big murmur.
Perfect. Yeah. We already talked about the benefits of cardioversion here, so we're going to quickly go over the wrong answers. Just a brief overview of the procedure itself, because this isn't like a procedure episode, and the boards are never going to ask you how to cardiovert someone. Hopefully they don't. In general, of course, you're going to place anterior-posterior pads. You could do anterior-lateral, but anterior-posterior is preferred. Once you do that, you're going to consent the patient for sedation. They're definitely going to be asleep for this. I personally this is where it's getting off into your own personal practice. I personally love to use automedy for this. It's fast on, it's fast off. Great, that's awesome. I knew we would agree. Of course we would.
Yeah.
And that's the best agent you should be using. It's quick on, it's quick off, and the dose is going to be 0.1 mg per kg. And let's say that doesn't work. Let's say you can't do that. Let's say you don't have that. Yeah, you can do propofol. That's fine. But they definitely need to be asleep for this. This is a painful procedure. What are you shocking them at? Your joules?
150, 200.
Yeah. I go big or go home every single time.
200.
I go max dose every single time, 200. But yeah, 150, 200. Definitely not 50 or 100, whatever they say, in the incremental doses. Your aim here is to do one shock, and that's it. And then there's some questions that people often ask me of how many times you're going to shock them if it doesn't work. Well, if it's not meant to be, it's not meant to be. And I tell patients that beforehand, before we put them to sleep. I would say, hey, there's a chance that we just can't get you back into sinus rhythm. We will wake you up, of course, if we can't get that. I personally, I'm going to knock on wood, personally have not had that happen yet. But when it does happen, I'll probably try it, 3 to 4 times maybe. And at that point, it's either something structural or just it's not meant to happen. Maybe the pads. Definitely before that happens, let's say we try shocking twice, doesn't work. I definitely do vector change. I change the pads. We change the angles. It's just all about positioning the patient in a different direction. If that's unsuccessful, though, they will admit them to the hospital and they'll go through the typical route. Anything else to add to that?
You can try a mag bolus with your
That's great.
shock.
That's
I
great.
always do that. I love a little mag bolus with my shock.
That's great. And it'll be even better when you know how to remember to order the mag, beforehand, because it doesn't come automatically. Someone should be arrested for letting that happen.
I know.
Every time you got to think about ordering it.
Big lab. It's a big lab conspiracy.
It must be. It must be some new thing that's going on. Let's go over the answer choices here. So choice B was saying you should only do the cardioversion in this patient to get a CT head. I pulled that one from complete left field. That's absurd. Don't do that. CT head has 0 role in routine AFib evaluation unless they have like focal deficits and you're calling it code stroke, obviously.
Yeah, you should be going down a totally different pathway.
Totally different pathway, exactly. Choice C was talking about only cardioverting if it's less than 12 hours. Dr. Wosiski-Kuhn, debunked that already. That's a made-up rule. The evidence supports less than 48 hours as the window. And choice D was saying never do this at all. I feel like that was like a cardiologist wrote that. This is incorrect. This is definitely in our wheelhouse. Definitely something we could take care of. And then, of course, we talked about the anticoagulation, the CHADS-VASc score, 0 to 1, onset less than 48 hours equals no anticoagulation required. If it's greater than or equal to 2 CHADS-VASc, you should start anticoagulation after cardioversion. Typically speaking, this is debatable, but it's typically about 2 to 3 weeks of like Eliquis or Xarelto, neither of which we're sponsored by.
If you want, just talk to whoever you're going to have them follow up with because they're going to be taking them off of it. So say,
perfect.
What do you want me to do and when do you want me to have them follow up with you? Because that's the person that's going to take them off of it. So you might as well just do what they want.
That's perfect. Let's say a patient refuses cardioversion. Let's say they don't want to be admitted. They don't want to be shocked. You could always send them home on metoprolol and hope for the best or oral DILT. And that's great. But I've never had a patient decline this. They're like, sure, let's get it out of the way.
Yeah, because I'm always like, that's what I would do. And they're like, sweet, okay, let's do it.
Exactly. Perfect. Hey, let's do some coaching. And there's 6 major pearls here I want you to go over. And I'll hold up fingers to keep track.
All right, let's do it. Here's some coaching on holiday heart, AFib, cardioversion, and the ED. So 1, reliable onset is king. If it's unclear when the onset was, don't cardiovert them. 2, holiday heart is cardiovertible. It is the best for cardioverting. Don't let alcohol bias make you think that it isn't. 3, a normal bedside echo increases your confidence, but you don't have to do it. 4, if the patient is older, sick, if they've got a lot of comorbidities, start anticoagulation afterwards. 5, if the rate won't budge or if the patient is miserable, cardiovert early. 6, don't delay over 12 hours waiting for spontaneous cardioversion. It's rarely going to happen once they hit the ED. They're there for a reason. Get it done.
Get it done. Cool. All right. Remember to check out Rapid Bombs on our website. Just go to eatmorebombs.com. Great holiday gifts. Great stocking stuffer. Virtual stocking stuffer.
Yeah, virtual stocking stuffer. I don't know. Maybe you're a senior resident and you're mentoring an intern and you really want to help them out.
That's sweet. Well, in that case, if you're a senior resident, you need to email us and ask for a group sponsored rate for your whole program.
Yeah.
Which we have several programs now. Some big name ones too. I won't name them. I don't want to call them out. I don't want to embarrass the ones that aren't signed up yet. But I don't know. Only the cool programs are part of it so far.
Yeah, probably want to do it.
All right, well, that's it.
Wait, Dr. Briggs, what's your favorite Thanksgiving food?
Oh, it's definitely sweet potatoes.
Sweet potatoes.
Yams. Definitely yams.
Very southern of you. You mind mashed potatoes and gravy, but it's really close up there with stuffing, which I feel like should be eaten more often than just Thanksgiving. Like you only get to eat it once a year.
Stuffing is underrated.
I love stuffing.
Yeah, it's really good. What else do I like? I went through a green bean casserole phase recently. That was pretty good too. But yeah, it's definitely sweet potato yams. Definitely yams.
Yeah,
but people around the world are listening like, what?
Yeah, and it's crazy that Iltafat likes fruitcake the best. That's definitely...
Yes, something we have found out about him. It's because he's an associate professor.
Yeah,
anyway,
it must be.
It's been real.
All right, see you next time.
Catch you later. See ya.